Hello and welcome to the Dosing and Use of Pediatric Resources Review. I am Sarah Smith, Associate Professor at St. John's University College of Pharmacy. I had help creating this presentation from Brianna LaRussa, PharmD candidate at the University of Florida. We have nothing to disclose related to this topic. The purpose of this session is to help you become more comfortable dosing medications in pediatric patients, selecting dosage forms, and using pediatric-specific references. This is a list of abbreviations commonly used in practice, and during this session, you will want to become familiar with these. At no other time in a human's life will the body change as much as it does when progressing from a neonate to an adult. Categories that align with the developmental stages are used to provide context for patient care decisions. Neonates are the most vulnerable group. They're composed of people during the first 28 days of life. It's during this time that renal clearance is really slow, volume of distribution is really high, and the blood-brain barrier is leaky, which increases susceptibility for central nervous system infections and things like kernicterus. Infants represent people during the first year of life after that neonatal period. Children are technically anyone greater than 1 year of age up to 12, and then adolescents rounded out as from the period of 12 years of age up to 16. You want to make note of these age groups because they are used by the FDA during the drug approval process. So you will see these groups used in their pediatric dosing references. The European Medicines Agency also uses the term toddler to describe infants, so you may encounter that terminology on occasion. Classification of neonates also occurs by gestational age, weight, and comparative size. Gestational age tells us how premature the neonate is compared to a term neonate. Weight classification also communicates developmental status and indicates a level of risk for outcomes like bronchopulmonary dysplasia or an intraventricular hemorrhage. Gestational size compares the neonate to the rest of the neonatal population at that particular gestational age. It's a lot to think about there, so pause. Neonates that are small for gestational age are at a risk for the same outcomes as neonates that are more preterm but the same size. While term infants that are very large for gestational age are at a higher risk for brachial plexus injuries during birth and then hypoglycemia afterwards. Pediatric patients are a heterogeneous group, ranging in size from less than 600 grams to over 80 kilograms. The physiologic differences include changes in total body water, enzyme development, blood flow to end organs, kidney development, and even skin thickness. So these patients experience unique drug effects, adverse reactions, and age-related contraindications. These developmental differences also dictate which dosage forms can be used and how a medication can be administered. Let's take a deeper look at absorption, distribution, metabolism, and elimination during the pediatric period. We'll start with absorption. Enteroabsorption is dependent upon the development of the GI tract and is affected by the length of the small and large intestines and the gastric pH. So for example, in neonates, gastric pH is neutral and decreases to a more acidic level as the patient ages. Remember, pH changes drug ionization, and it can either increase or decrease the amount of drug available for absorption. This graph shows the effect of different gastric pH on the absorption of acid labile drug penicillin. In neonates, more penicillin is absorbed compared to infants and children. Other types of absorption are also subject to developmental changes. Percutaneous absorption during the neonatal and infant period is greater because of the thinner stratum corneum and the much larger body surface area to weight ratio. This effect is pronounced until 12 months. Then absorption through the skin is similar to that of the adult. Surprisingly, the bioavailability of an intramuscular injected medication is much greater during the neonatal period due to the capillary density of the skeletal muscles. So think of things like aminoglycosides and beta-lactams that sometimes we have to administer to our babies intramuscular because we don't have a peripheral IV or can't get one started. That would be this case. Those are compared to adults, of course. Neonates absorb about 56% more of an injected medication like an aminoglycoside or a beta-lactam when compared to adults. So it's pretty significant of a difference. Once the medication is absorbed, it is distributed throughout the body based upon solubility, protein binding, and its lipophilicity. As age increases, total body water decreases, resulting in a progressively smaller volume of distribution. Fat composition actually increases with age, which means that the volume of distribution for lipophilic medications is going to also increase. Protein binding also changes as it's lower in the neonatal and infant period due to fewer proteins circulating. And this means that the volume of distribution will be lower. And remember, the free fraction, which is the active drug, is also going to be altered. Metabolism is also an important pharmacokinetic parameter to think about when looking at developmental changes, especially related to enzyme systems. Cytochrome P450 enzymes are expressed at varying capacities at birth. CYP2D6 is fully functional within the first 2 weeks of life. CYP3A4 is not fully mature until about 12 months of life. So drug metabolism can lag until the enzyme maturity is complete. The liver's capacity for glucuronidation is not reached until after 3 years of life. This relative deficiency is most noticeable during the neonatal period and is a reason we can see things like kernicterus, gasping syndrome, and gray baby, especially if appropriate measures are not taken to prevent the accumulation of toxins. Another example is the delayed development of alcohol dehydrogenase. This enzyme is not fully functional until after the infant period, so we avoid elixirs during the first year of life. Elimination of metabolites and unchanged drug also changes with development. Glomerular filtration is limited during the first year of life and is a reason longer dosing intervals are used. Tubular secretion and the ability to concentrate urine are just not as efficient during that first year of life. And this phenomenon is most easily appreciated during the neonatal infant period when you're trying to replace sodium losses and you're using large doses of sodium that you would never use in an older age group. Renal perfusion is heavily dependent upon prostaglandins and renin during the first few months of life. So caution must be taken if you're using medications like NSAIDs or ACE inhibitors that will alter prostaglandin renin production or change receptor binding. These medications can decrease blood flow to the kidney, and then they can result in acute kidney injury. Now you have an appreciation of the pharmacokinetic differences experienced by pediatric patients. Let's look at the methods used to derive medication doses for pediatric population. Historically, pediatric doses were derived from adult doses by assuming physiologic changes were linear and then setting up a proportion. However, growth and development are not linear processes strictly related to age or weight. Thus, the phrase, "children are not little adults," describes precisely why Young's rule and Clark's rule do not work. Age-based dosing is easy to use but doesn't recognize the physiologic differences or that patients do not grow at a rate that's dependent upon age. Age-based dosing is not a commonly used method, but it is acceptable in certain situations, such as intrathecal dosing or dosing of immunizations. Body weight is used more than any other method to determine dose. This is because body weight has proven to be the most accurate for neonates, infants, and children. Body weight dosing accounts for the need of larger doses per body weight as a function of increasing clearance. However, body weight dosing can overdose patients weighing more than 40 kilos. Therefore, maximum doses are set. Usually, the adult maximum is the default maximum we use. Finally, dosing medications by body surface area is the most accurate for dosing medications in adolescents, and thus is used for dosing chemotherapy. However, this method is not perfect. Dosing per BSA can overestimate doses for patients that are less than 12 years of age, and this is especially important in the infant and neonatal period due to their large body surface area per unit of weight. The BSA calculation can also be cumbersome. You have to have an accurate weight, an accurate height or length every time you calculate it. And there are several different formulas that can be used to calculate the BSA. And so the team has to agree upon which formula they're going to use. In summary, there are a few rules for dosing medications which can help you. Weight-based dosing is the most common method. Do not exceed the adult maximum dose. So be cautious when you're calculating doses for patients that are 40 kilos and above. Always double-check doses of medications that can kill a patient with a simple miscalculation or a misplaced decimal point. I call these the 5 deadly drugs: insulin, morphine, potassium chloride, digoxin, and heparin. Always double-check those. Getting an accurate weight can be a challenge at times. Knowing the usual weights at different points during development can be helpful. The average newborn weighs about 3.5 kilos, and during the first year of life, they will triple their birth weight. Weight increases by about 2.2 kilos a year until puberty. The usual weight of a 5-year-old is 20 kilos, and that of a 10-year-old is 30 kilos. Height or length is not often used to determine dosing, but for body surface area calculations, you have to have it. Most infants are about 20 inches long when they're born. 3-year-olds are about 36 inches, and 4-year-olds are about 40 inches in height. Children can be expected to grow an average of 2 to 3 inches a year until puberty. Body mass index is a way to compare overall growth of one child to others of the same age and sex. Ideal body weight is the 50th percentile on the growth curve. BMI is used to determine the weight categories of underweight, overweight, and obese. About 20% of children are considered obese, and this is an important characteristic to incorporate into medication dosing. Obese patients experience altered pharmacokinetic parameters. Unfortunately, we just don't have great data that has dosing strategies for obese pediatric patients. You will find that you need to consult the literature for guidance most of the time. When figuring out a dose of medication for use in obese patients, the volume of distribution and clearance are used. Volume of distribution is best represented by total body weight, and clearance is actually best represented by the lean body weight. So what this means is drugs that have a smaller volume of distribution and a narrow therapeutic index will utilize ideal body weight for dosing. If the therapeutic index is actually considered wide, then the adjusted body weight is used to calculate the dose. Now, adjusted body weight is 25% of the difference between the actual body weight and the ideal body weight. The 25% is the increase in the lean body weight of an obese patient compared to their non-obese patients in the same cohort. So keep in mind that this adjusted body weight formula can actually vary a little bit depending upon what the available data is and what the drug properties are. Sometimes the adjusted body weight will be 40% of the difference between the total and the lean. Sometimes it will be 20%. If no available data is around, then it's customary to use the 25% difference. For medications that have a larger volume of distribution, considering the therapeutic index, if it's a narrow therapeutic index drug, again, you use the adjusted body weight. If it's, however, a wide therapeutic index drug, you can just use the total body weight, which this makes sense. If you have a very large volume of distribution and there's a wide margin for error, it's pretty safe to use the total body weight. Luckily, most medications in the pediatric population can be dosed by total body weight, but being familiar with the exceptions is a great idea because it will prevent adverse effects and then the toxicities that are associated with excessive dosing. This is a list, not complete, but it's a list of medications that should be dosed according to ideal body weight instead of total body weight or adjusted body weight. Some of the medications are just narrow therapeutic index medications. Others are hydrophilic medications, and thus they don't distribute into the extra adipose tissue, so ideal body weight is a better predictor of their dose. And then the last category are those that are at a high risk of accumulation because they are so lipophilic, they accumulate and stay in that extra adipose tissue. So using many loading doses based upon the total body weight of the patient to achieve an effect, because most of these are sedatives, right? And then you switch to ideal body weight for maintenance dosing is thought to provide one of the best dosing strategies for balancing the desired effect and avoiding excessive toxicity related to accumulation of drug. Next, we will examine dosage form selection. It doesn't matter how correct the method for dosing we use is, if we can't safely get the medication into the patient. There are several considerations for dosage form selection. The ability to use different dosage forms varies greatly due to age, physical development, dexterity, and psychological development. You must also consider the patient's medical condition and related limitations, the palatability of the enteral products, and then the most basic obstacle, which is availability of the dosage forms. Dosage forms are not always manufactured for use in children and babies. Manipulation of dosage forms may be necessary to enable use in the pediatric population. We split tablets when they are scored, and we try to avoid crumbling. We make aliquots, we open capsules, and sprinkle the contents on food, realizing that the patient's got to eat the food. We can use some injectable medications enterally, as long as the bioavailability is maintained. And we can compound dosage forms if we have stability and bioavailability data. It is not easy, but we do have methods to ensure our patients get what they need safely. When selecting dosage forms, we must also consider which dosage forms are appropriate for the patient based upon their age and physiologic development. This is an illustration of when dosage forms are developmentally acceptable for use. Preterm neonates are managed with parenteral medications and an occasional suppository to minimize the osmotic load medications have on the gastrointestinal tract. Enteral formulations can be used, but with caution. Term neonates and infants are more tolerant of enteral solutions as the gastrointestinal tract has further developed. We can use masks and spacers to deliver metered dose inhalations, and nasal administration of medications is also acceptable. Children 2 years and older have teeth, so they can chew tablets. They can also follow simple instructions such as holding a disintegrating tablet on their tongue. It is at this age that we can safely use transdermal patches, so long as they don't pull them off. This age group can also manage the use of dry powdered inhalers. By 6 years of age, children can physically swallow tablets, capsules, or hold a buccal tablet or sublingual tablet in place. As children approach adolescence, their preferences begin to dictate which dosage forms will be used. They do not like suppositories or enema, and they would rather use an MDI over a nebulizer. And this age group is also able to self-administer injectable medications. And finally, we cannot neglect the size of the patient and the limitations of the route of administration. When patients are being treated at home, the majority of medications are given orally, per tube or per rectum. In acute care settings, parenteral medication is administered because patients often are not able to tolerate enteral administration. Intramuscular and subcutaneous routes are limited by volume, while peripheral and central line administration are limited by the osmolarity of the medication. It is of utmost importance to make sure the device measuring the dose is accurate. Oral syringes and measuring spoons are considered accurate devices. However, spoons pulled from a kitchen drawer vary in size and are not considered accurate. Palatability can keep a child from taking the medication. They can spit it out, or they refuse to open their mouths if they don't like the way the medication tastes. Refrigeration and flavoring can help and should be utilized when necessary. Needing to take the medication many times a day will also impact adherence. Choosing formulations with once daily or twice daily dosing improves adherence by avoiding the need to administer the medication while the child is at school or attending day camp or just away from the home. Preparing the patient and the caregiver on what to expect and how to minimize adverse drug reactions that are known, for example, taking a sedating medication prior to bed instead of just in the morning, will also help improve adherence to therapy. Let's do an example. 4-year-old Sadie Sue was admitted for cellulitis. She weighs 17 kilos and has no known drug allergies. The team started clindamycin 7.5 milligrams per kilo IV Q8, which is about 127.5 milligrams, or if you round it up, it's 130 milligrams. After a day of treatment, the infection was resolving, so she was discharged on clindamycin oral solution. However, 3 days later, she returns to the ED with the same infection and a fever of 101.2. So what do you think happened to poor Sadie Sue? When talking to Sadie, she tells you that the clindamycin was yucky times 8. In this case, flavoring the clindamycin or choosing an alternative medication like Bactrim may have given us better results. It can be challenging to come up with alternatives or suitable therapies for our special patients. However, as pharmacists treating pediatric patients, you do have resources.
The next section will provide an overview of resources dedicated to providing care for pediatric patients. There are 6 resources devoted to the use of medications and proper medical care of children. The references listed here are reliable and evidence-based. The Pediatric and Neonatal Dosage Handbook is the go-to for quick drug information concerning the pediatric population. It highlights items of particular interest for the pediatric pharmacist, such as administration, dosage forms, and extemporaneous preparation. There's a back section of special topics and charts which contain vital information ranging from how to calculate fluid replacement to steroid and narcotic comparison charts. It is a living reference that is updated continually when using the online version and annually for the print version. It is authored by pharmacists. The Pediatric Injectable Drug Reference focuses on the unique issues related to the use of injectable medications in pediatric patients. Topics such as the maximum concentrations, diluents, rates of administration, and other routes of administration are included. This reference is authored by pharmacists and is updated every 3 years. Pharmacotherapy focuses on the unique therapeutic needs of neonates, infants, children, and adolescents. The second edition of this textbook includes up-to-date pharmacotherapy for pediatric-specific disease states, prevention of medication errors, and patient-caregiver education. The text has patient-specific cases in all disease-specific chapters that were developed to help readers apply the information presented in each chapter. Cases highlight common pediatric disorders or diseases that may be encountered in clinical care in an ambulatory, community, or acute setting. This text is also authored by pharmacists. Nelson Textbook of Pediatrics is the reference of choice among pediatricians, pediatric residents, and others involved in the care of young patients. It provides a concise, easy-to-use format for everyday reference and study. This reference is updated every 4 to 5 years and contains information not only about therapeutic modalities, but also global health, racism, media violence, gun violence, parenting, all the way to gene editing. This resource contains evidence-based answers on every aspect of pediatric care. Please note this text does not contain specific drug information or detailed information about pediatric nutrition. The Red Book is a trusted guide on pediatric infectious disease prevention, management, and control. This is an evidence-based guidance on pediatric infections and vaccinations. It is updated every 3 years by representatives of the American Academy of Pediatrics Committee of Infectious Diseases, CDC, and FDA. Neonatal and Pediatric Pharmacology provides an overview of all aspects of drug therapy in newborns, children, and adolescents. It offers evidence-based guidelines for safe, effective, and rational drug therapy, including specific recommendations for all major drug classes and diseases. This text is comprehensive, addressing pharmacokinetic, pharmacodynamic, pharmacogenetic, and pharmacoproteomic issues in special populations, as well as drug development and clinical trials in infants and children. Let's practice with an example. An 11-year-old male is bitten in the buttocks by a stray dog. The bite broke the skin and penetrates the muscle. Luckily, his immunization status is up to date, but he is asplenic. Does this patient need antibiotic treatment for the dog bite? In this case, the best reference to use is the Red Book, looking under the immunocompromised patients since he is asplenic. The Red Book recommends amoxicillin clavonate 45 milligrams per kilogram by mouth for 2 to 3 days. His dose would be 855 milligrams since his weight is 38 kilograms. A new tool has been created by pharmacists to help pharmacists manage key potentially inappropriate drug use in pediatric patients. The Kids List is a list of medications that carry excessive risk when used in the pediatric population. It is evidence-based and contains recommendations on how to minimize the associated risk. It will be updated as new information becomes available and at a minimum of every 5 years. And that brings this session to an end. In summary, dose calculation based upon developmental physiology is essential. Doses based upon weight and BSA are utilized most often in the pediatric population. When selecting a dosage form, consider patient-specific factors and the social support system of that patient. Use the pediatric-specific references available to provide the most accurate dosing recommendations. And finally, incorporate the Kids List into your daily practice as an extra measure to ensure safe medication use in children. Question 1. A baby is admitted to the hospital for treatment of a urinary tract infection. The patient is day of life 20 following a full-term pregnancy and weighs 3.9 kilograms. Which classification most appropriately describes the patient? A. Low birth weight infant. B. Low birth weight neonate. C. Neonate. D. Infant. And the answer is C. Neonate. Question 2. How is the dose of a hydrophilic medication different for an infant compared to an adolescent? A. The interval is shorter. B. The volume of distribution is larger per kilogram. C. The interval is the same. D. The volume of distribution is smaller per kilogram. The answer to this question is B. The volume of distribution is larger per kilogram. Question 3. A 13-year-old female is post-op following an emergency exploratory laparotomy for grade 4 liver laceration. She weighs 85 kilograms, and her ideal body weight is 40 kilograms. She has no drug allergies. Which dose of morphine is most appropriate? A. Morphine 4 milligrams IV every 2 hours. B. Morphine 2 milligrams IV Q2 hours. C. Morphine 5 milligrams IV Q2 hours. D. Morphine 1 milligram IV Q2 hours. The correct answer is B. Morphine 2 milligrams IV Q2 hours. This is because morphine is a hydrophilic medication with a high risk for overdosing, so her ideal body weight is used to calculate the dose. And then the dose is titrated to the desired effect. Question 4. A 2-year-old patient is being treated for dehydration due to rotavirus infection. The patient is unable to tolerate enteral formulations and does not have an enteral tube placed. Which is a viable alternative dosage form for control of the patient's nausea? A. Scopolamine patch. B. Ondansetron IV. C. Ondansetron ODT. D. Promethazine suppository. The answer to this question is B. Ondansetron 2 milligrams IV once. This is because venous access has probably been established, which would make ondansetron an easy dosage form to use. Scopolamine is an option if the patient will try not to remove it, and the disintegrating tablet is not a sure bet as the patient is not tolerating anything by mouth. Promethazine is on the Kids List and it's not recommended in children this age. Also, diarrhea will make a suppository very ineffective. Question 5. A 6-year-old patient was just diagnosed with Lyme's disease and needs to be treated. Which reference would have the most up-to-date information regarding antibiotic regimens? A. Pediatric and Neonatal Dosage Handbook. B. Pediatric Pharmacotherapy. C. Neonatal and Pediatric Pharmacology. D. Red Book. The correct answer is D. Red Book. The Red Book is the standard for infectious disease-related therapeutic information. A is not correct because this handbook does not contain treatment plans. C is incorrect because it will contain information about the pharmacology of the medications but not the preferred agents.